link.
Location? I mean, I would imagine the placenta will have a different characteristic of sound in a different location in the uterus.
It might, but how do you determine which one? Because how do you determine which one is coming from the umbilical vessels? Because when you're hearing the blood flow through the umbilical vessels, is that more related to the fetus or to the mom?
Fetus.
And when you're hearing, so correct. And then if what you're hearing through the uterus, is that more related to the fetus or to the mom?
Mom.
So how can you distinguish them?
Is it gonna be pitch?
You won't really be able to distinguish that. What you need to do, right, is to try to correlate what you're hearing to the mom's cardiac rate.
So what's matching up to the heartbeat?
So you're listening and you're palpating the mom's pulse while you're listening so that you can make that correlation so you can determine which one you're hearing, okay? Okay. Now, important point, fundal height. Fundal height. As the fetus grows, so first of all, what is the fundus? What part of the uterus am I talking about?
The top.
The top.
The top, the most muscular part of the uterus, okay? So, fundal heights. As the fetus grows, the fundal, the fundus is going to ascend, so the height will increase. So I'm going to kind of start in the middle, which might seem a bit confusing, but I think it's a landmark that you can understand, and then I'll drill it down a little bit. At 20 weeks, the fundus should be at the level of the umbilicus. 20 weeks, the level of the umbilicus. At 36 weeks, it should be at the xiphoid process. At 36 weeks at the xiphoid process. Okay, so you have your two major landmarks there. Now, at 12 to 16 weeks, it's going to be kind of midway between the symphysis pubis and the umbilicus. So, excuse me, a little bit less defined, but kind of midway there between the symphysis pubis and the umbilicus.
I'm sorry, how many weeks?
Between 12 and 16. So some of that you will have to, remember that your assessment isn't the only part of your assessment. You're combining this with other information, but 20 weeks at the umbilicus, 36 weeks at the xiphoid process. Now, in a woman who is of average height and with a BMI that's within the normal range, the fundal height should correlate with the number of weeks of pregnancy after 18 weeks. So you should see some correlation there.
Professor, can you
again, that depends on the patient being of average height and with a BMI within normal limits. So that is actually a small segment of the population. You're not going to find that many people that actually fit that. But just so that you know that the number of weeks after 18 weeks, the number of weeks correlates with the number of CMs above the symphysis pubis. So okay, I have another picture that I didn't give you. Okay. So let's say you are assessing someone who is 32 weeks. If you're assessing her, she's 32 weeks manually without any measuring tape, where do you expect the fundus to be? Where do you expect to find the fundus?
Below the
Midway
cost
between
of-
the umbilicus and the xiphoid process.
Midway, that's right. So that's what I want to hear, not just one landmark, right? So midway between the umbilicus and the xiphoid process, probably closer to the xiphoid process than to the umbilicus, right? Now, if you're measuring with a tape, if you're measuring from the symphysis pubis, she's 32 weeks, the fundal height should be approximately 32 cms above the symphysis pubis, because it
I'm
should
sorry,
kind
Can
of
you just
correlate with the number of weeks.
sorry, Professor, can you just repeat the part that you said about BMI?
I said someone who is of average height, whose BMI is within normal limits.
So, Professor, so what you're saying, based on the weeks, it's 1 centimeter difference per week?
So you understand 20 weeks and 36 weeks. We're clear on that, yes?
Yep.
Okay. Now, what I said is after 18 weeks, if you measure with the measuring tape, the number of weeks should correlate to the number of cms above the symphysis pubis, that the fundal height is above the symphysis pubis. But that is only true after 18 weeks if she is of average height and with a BMI within normal limits. I don't want you to get caught up on that measurement. Now, I wish I almost didn't mention that. I want you to focus more on 20 weeks, 36 weeks, where you expect her to be at 12 to 16 weeks, where you expect her to be at 32 weeks. Okay?
So
This is
Professor,
not the
do-
last you're going to hear of this. Okay?
Okay.
Now, 36 weeks at the xiphoid process. So I want you to gently, for yourself, feel where your xiphoid process is so that you understand why there is such dyspnea at 36 weeks. The fundal height is all the way up there, okay? So that is why the respiratory, there's some respiratory compromise, which we're gonna talk about in a few minutes. Now, that's at 36 weeks. At that point, the fetus is in the abdominal cavity. After 36 weeks, lightening occurs, and that is when the fetus drops into the pelvic cavity. So the fundal height after 36 weeks will actually be lower than the xiphoid process, because the fetus has now dropped into the pelvic cavity and getting ready, you know, in preparation for delivery. All right. It's not an overnight process. So it's a process. So 36 weeks, the fetus descends into the pelvic cavity. The fundal height is going to be lower than it was previously. Okay. So let me ask you this in relationship to what we spoke about yesterday. Tell me about a mom whose BMI, tell me about a mom whose the fundal height, you might expect it to be lower than where it should be for her gestational age. So you have a mom who is 20 weeks and her fundal height is 3 cms below. It's below the umbilicus. It's below the umbilicus, and
The
she's
fetus
20
is
weeks.
undersized, yeah?
What might be the cause?
The fetus
Higher
is
BMI.
undersized, yeah?
So I'm going to ask you to put it in the chat box just so that I can get all of the responses without. I need to respond to. So remember, I said the fundal height is below. If the fundal height is below, does that mean the fetus is bigger or smaller than expected?
Smaller.
Smaller, smaller. Doesn't mean smaller. So what are some of the reasons that it might be smaller? There
Undernourished.
might be, she might have a low BMI, she might be malnourished, yes, she might be underweight. What else? So I saw that somebody mentioned preterm.
Oh,
Remember, the dates may be off, right? Her dates may be off. Or our dates may be off. Maybe we made a mistake on the ultrasound. Maybe the ultrasound wasn't read correctly. Okay, so again, I want you to start thinking about how all of these things play into what we've talked about on previous days and start making these connections. It could be an issue with oxygenation. Absolutely. This fetus needs glucose and oxygen to grow. If she's not well nourished, if she's not well oxygenated, you're going to see it somehow. So Simona, you wrote amniotic fluid. What about amniotic fluid?
the amount I was thinking, I don't know.
I want, no, you know, but I want you to be more specific about that. I'm talking about a fundal height that is lower than where it should be. So are we talking about oligohydramnios or are we talking about polyhydramnios?
Exactly. So could be
I'm
that the
asking you
amount
though, which one are we talking about?
oligo.
Right,
Oligo.
so there may be an issue with
Reduction.
she has less amniotic fluid. Okay, yes, she may be a smoker, and we're going to talk more about the impact of smoking. So all of these things, there can be anomalies in the fetus. All right, so all of these things you have to start to connect these pieces. Okay. All right. Okay, cervix. So, due to the increased level of estrogen, again, one of the pregnancy hormones, and also due to the increased perfusion, the cervix becomes hyperemic. So there's so much of an increase of blood flow that the color actually changes. And so Chadwick's sign is this bluish purplish color that we see to the cervix, sometimes to the vaginal walls, and sometimes even to the labia, okay, due to the increase in vascularization. Godel's sign is the post-conception cervical softening that occurs.
Professor, the Chadwick sign, it becomes bluish purple because it has high estrogen.
Perfusion.
In estrogen and increased blood flow to the area.
The estrogen causes increased blood flow.
So both
Right.
of them. Remember, if there's a pregnancy, we talked about this, right? Because of the pregnancy, the entire reproductive tract is going to have increased blood flow. So the increased blood flow and the increased estrogen.
So Chadwick sign is normal?
Yes. Yes. It might sound crazy, but it is normal. Yes.
Okay.
Because that is what it's due to. Okay. So it is normal. Godel's sign. Before conception, the cervix feels like the tip of your nose. With the hormones, Godel's sign is the softening of that cervix, and it feels more like your lips. Okay, just so that you have a sense of what that difference in feel feels is like. All right. Now, the mucus plug, what we commonly call the mucus plug, the name for it is the operculum, and you will hear me refer to it as both of them, but you should know that that is what the operculum is. All right. So the operculum is this kind of plug of mucus secreted by the cervical glands. So it forms a plug that is here that closes off the cervix. So this is an important measure of protection for the fetus, the operculum and an intact amniotic membrane. So an intact amniotic membrane as well as the operculum. Let me just see. Okay.
Professor, what is the intact amniotic membrane plus the operculum?
Those form barriers of protection for the fetus.
Okay.
I have a question.
Yes.
In that image that you just had up, there's the plug, and then on the uteral side, it looks like there's another tissue that goes over that area. Is that just the uterus?
Can you see my, I'm not sure if you can
Yeah, I
see
can
my
see it.
pointer. You can see it?
Yep,
Yeah.
Okay, so is this what you're talking about
absolutely
here?
correct.
So this is your amniotic membrane,
Okay, Cool.
right?
thank you.
And this is the operculum.
Perfect.
Okay, so, and then up here would be your fluid, the amniotic fluid in your fetus and so on.
I was just impressed that it was just a mucus plug that was holding everything.
Well,
Like stopping everything out, but then there's that extra barrier, so it's kind of like two.
Right, and this closes off, whereas it's somewhat open. This would close off the space. Even though the cervix is closed, it's not like sealed, you know what I mean? So it's, if you think of like a sphincter muscle closes, but it's not sealed, right? There's still like a little bit of an open. Okay, so that's our operculum, amniotic membrane. All right. So we already talked about Chadwick's sign.
I have a question regarding the mucus plug. How does it relate with the infection?
So this is, so if your fetus is here, right? Your fetus is up here. You need a barrier, right? So you have one thing, this is your amniotic membrane, that's one barrier, and the mucus plug is another barrier. So what both of them function to prevent any bacteria, any infection, any microbes from ascending up and in to the uterus.
Okay, thank you.
Okay. Okay, so we talked about Chadwick's sign already, the increased vascularity, the bluish purplish coloring. The connective tissue, the vaginal walls also have this increased vascularity. And so the vaginal mucosa thickens, the vaginal rugae, the folds within the vagina become much more prominent. The increase, and we'll talk more about, I'll talk about this also when we get to psychosocial, but the increased vascularity can also heighten sexual interest and sexual pleasure because of the increased vascularity, increased sensitivity to the area. Let's press, okay. The other changes, the pH. So vaginal mucosa thickens, the secretions and discharge can increase. The pH is 3.5 to 6, somewhat acidic to prevent bacterial growth. But I want you to think about this. You have an area that is moist, dark, and warm. Perfect setup for infection, right? Perfect setup for infection. Now, with an increase in discharge and secretions, any microbes that if there's a misbalance of the normal flora or any microbes that are advantageous can grow. Now, because the vaginal secretions are rich in glycogen, that can promote growth of Candida albicans, which will cause what?
Yeast infection?
Yeast infection.
Infections, right? Candidiasis. So this is one of the reasons that we do see more yeast infections during pregnancy. It's just one of the normal natural changes that happens with pregnancy, but it predisposes her to more yeast infections.
Professor, this might be a silly question, but if the mucus plug prevents bacteria, so it prevents bacteria from ascending up, but it still allows for like the extra secretions and discharge to come out.
Yes.
Right, because remember think about your anatomy. The operculum is in the cervix, which is above
Yeah,
the area that we're talking about now.
okay.
This is lower. Okay, so what I said was that you have an increase in vaginal secretions and discharge, and that they are glycogen rich. So that feeds any microbes and certainly will feed the Candida. Right.
What was the pH range you said?
I can't hear your question.
The pH range, what was it?
3.5 to 6. Okay. Changes to the breasts. So in preparation for lactation, the body is going to go through certain changes during the pregnancy. So estrogen is going to stimulate growth of mammary ductal tissue. Progesterone promotes growth of the lobes, lobules, and the alveoli. So the breasts become much more vascular. The veins become more prominent. The nipples increase in size and become darker, more erect. The areola become more prominent as well. So colostrum is actually present very early in the pregnancy, and many women will, excuse me, many women will have colostrum leak out during the pregnancy. So this is an important part of our teaching. You want to make sure that she knows that this is a normal, natural occurrence, okay? Because otherwise it can be very alarming for this to happen and she doesn't know that it's to be expected, all right? And we'll talk about lactation when we get to postpartum and newborn nutrition, okay? All right, on to the interesting stuff. So before we go on to the interesting stuff, let me go back. Questions?
All of this is interesting stuff.
All right, well, I hope it stays interesting. I hope it stays interesting. Okay. This is personally where I think it really gets interesting. Okay, cardiovascular. Lots of changes occur with the within the cardiovascular system. So I'm going to preface this with saying that there is a significant increase in, I'm going to preface this with saying something, and then I'm going to ask you a question and ask you to put the answers in the chat box. So there is a significant increase in vascular volume during pregnancy. So remember what we've talked about, tissue growth. If tissue is growing, it has to be perfused, right? It has to get the oxygen, it has to get the glucose. It's only going to happen if you have an increase in perfusion. So there's a significant increase in vascular volume. In addition to tissue growth, what is the purpose of that vascular volume? What is the purpose of that vascular volume? I'm going to open the chat box so I can see what you tell me. So Fred, I want you to drill that down. So I see you guys talking about, I guess, talking about the fetus. Yes. I want you to, you've got to drill that down. I want you to think a little bit more detailed about that. But you're on the right path. So you seem to all be thinking about oxygenation and nutrition for the fetus. How is that fetus getting this oxygen and these nutrients? How? How is it getting there? How is it getting to the umbilical cord? So this is why I said, remember I said to you last week, the anatomy is crucial, okay? You've got to have a good handle on this anatomy, right? The increase in vascular volume, it's important because that placenta has to be perfused. If that placenta is not perfused, it's not getting to the umbilical cord, it's not getting to the umbilical vessels, it's not getting to the fetus. The diffusion is not going to happen. None of that's going to happen, okay? The placenta has to be, the placenta itself is a vascular organ. It has to form, it has to be well formed, it has to be perfused, well perfused for any of that to get to the fetus. Okay, so let's not just jump from the mom to the fetus or from the mom to the umbilical cord. The placenta is crucial. And even though we never talk about it, or who cares? We never really think about it. Without that placenta, you've got no fetus, bottom line, okay? So now, having said that, the plasma volume, and I will go back to the heart, but I want to speak about this vascular increase, and then I think the change will make more sense to you. The plasma, okay. Hold that what I said about the placenta, just put that on the side for just 1 minute. When we look at, let's say you're looking at, for lack of a better container, this is what I have handy. Let's say this is full of blood. What exactly is in here? We have plasma, which is the liquid portion. And then we have the cells, okay? All right, so I want you to think about when the vascular volume increases during pregnancy, it increases by 30 to 50%, somewhere around 40% increase. That's a huge increase in the vascular volume, all right? Now, most of that is plasma that's increasing. The red blood cell mass is going to increase as well, but not as much. So if you have more plasma than you have cells, when you look at that, theoretically, that's anemia, right? That is anemia. So in pregnancy, when you have the liquid portion increasing much more than the mass of cells increasing, pregnancy, even if you have a mom that has a normal H&H going into pregnancy, the mere changes of pregnancy are going to give her what we call a pseudo-anemia of pregnancy, because she's going to increase the plasma volume more than she's going to increase the red blood cell mass.
That's why you give iron during pregnancy? No? Okay.
That's part of the reason, but not
But it's
exactly.
not, okay. It's not
So I'm just going to write, let me just write this in, and then I'll come right back to you. Just give me a second. Ruth, your question about fatigue, I will answer as we go through. If I don't answer it by the end of the day, let me know, but there are a couple of things that will address that. Okay, Simona, you were asking me something.
Oh, no, I said about the iron.
Okay, so part of it is that, yes, but remember, we've got all this tissue growth that is occurring. You guys did your nutrition charts, so you know what you need
Yeah,
all of that extra iron for. We have all of this tissue that is growing, and yes, the increase in vascular volume. So it's not just this; it's everything. Okay. All right.
Thank you.
So do we understand the concept of pseudoanemia of pregnancy, of the hemodilution that occurs? Okay. So now this increase in volume causes a slight myocardial enlargement. So remember, now the heart is working much harder. The heart is working much harder. So what happens when you work a muscle harder? It's going to thicken, right? The muscle's going to thicken. So you will have some myocardial enlargement. It usually reverses after birth. Sometimes it doesn't. There can be some really serious changes to the cardiac muscle that can occur with all of this. And we'll talk about that when we get to complications, when this whole situation goes haywire. We'll talk about that when we get to complications. For right now, I want you to just understand the basics of it. So the heart size can increase a little bit. Going back to what we talked about the fundal height increasing and moving up to the xiphoid process, when you get to the 3rd trimester, so remember your trimester weeks, as that fundal height is coming up, the diaphragm pushes up on the heart. So the heart is actually going to shift a little bit higher and to the left. So the position of the heart actually shifts towards the later in the 2nd, but definitely in the 3rd trimester due to this increasing uterine bulk, okay? So fundal height goes up, pushes the diaphragm up, the heart shifts up and to the left.
Does that affect circulation?
Does it affect?
Circulation.
No. What the body is doing is accommodating the pregnancy. And you will see there are many accommodations that the body makes for pregnancy. Okay, so we have a little bit of a change to the heart size, position changes, vascular volume changes. Now, the volume peaks at 28 to 32 weeks. So I want you to think about this. Remember what I said, your history is very important. If you're taking care of a mom whose baseline is chronic hypertension, when she's at 30 weeks, she's got a huge vascular volume. You got to stay on top of that blood pressure, right? This is when you got to zero in on your teaching. You got to make sure she knows what she's monitoring herself for. And we will spend an entire day talking about hypertension when we got to complications, but I want you to start thinking and pulling these pieces together, okay? If you're taking care of a mom who has a history of having a valve replacement, mitral valve replacement, if you're taking care of a mom who had a myocardial infarction in 2015 and now she's pregnant, that's a compromised heart, right? She had a heart attack 5 years ago. So she's got some tissue damage and now we're going to overwork that heart, right? So I want you to think about how you have to apply, think about the history, what these particular details of the history can mean and how does that apply to this situation, all right? And what does that mean for your teaching?
Question, is this when preeclampsia winds up happening at this point?
So preeclampsia is one of the conditions. Hypertensive disorders during pregnancy are a continuum, and preeclampsia is one of them. Mm-hmm.
So in cases like that, Professor, let's say hypertension is a factor. Obviously, certain medications are teratogens. How will we control it aside from nutrition-wise?
So these are, it has to be very holistic. So yes, you're looking at medication, you're looking at nutrition. You want her to be well hydrated. So you have to really, it's going to depend on how severe her hypertension is. There are hypertensive meds that can be taken throughout the pregnancy, but you certainly want to work with her on managing her sodium intake, on managing her fat intake, on that sort of thing. You do, as much as you can. And
Thank you.
again, we'll talk more about that when we get to complications, but I definitely want you to start thinking along those lines. Yeah. Okay. Okay, so back to our heart. Increases in heart rate. During the second trimester, the heart rate will increase 10 to 15 beats per minute. During the third trimester, 15 to 20 beats per minute. You get a lot more volume that the heart is working. So you will see an increase in the rate, 10 to 15 beats per minute in the second trimester, 15 to 20 beats per minute in the third. Sometimes these moms will develop a soft murmur. That is possible as well, just as a side note. What was the question? Andres, was that you?
Yes, I didn't hear the third semester, how many beat per minute increase?
Third trimester, 15 to 20.
Yes, third. Okay, thank you.
All right. Okay, blood flow. So we spoke about that. Now, in addition to the tissues, the growth of the tissues, perfusion of the placenta, remember that the kidneys have to be perfused, because even more perfused, because it's not just mom's waste that the kidneys are managing, but the waste of the fetus. So the blood flow through the kidneys increases about 50%. The skin is growing and expanding. There's going to be increased perfusion to the skin as well. Peripheral vascular volume. Oh, cardiac output. Sorry, I didn't mean to skip that. Cardiac output. So we have an increase in vascular volume. The cardiac output will increase 50%. During the first half of the pregnancy is when that increase occurs, and then it remains elevated throughout the pregnancy. So you will see an increase in the cardiac output during the pregnancy. 15.
Cardiac output increases 50 or 15?
I'm sorry. The 15 was to the chat box. I'm sorry. 50.
Oh,
So cardiac
50.
output 50 will increase
Okay.
50%
Okay.
during the pregnancy. Peripheral vascular resistance. Peripheral vascular resistance will decrease. The smaller vessels, the muscles of the smaller vessels will relax, and some of that blood flow will go to the placenta. So peripheral vascular resistance decreases, which predispose any patient who has a decrease in peripheral vascular resistance. What does that predispose the patient to?
So vascular, do you say
Edema.
To edema, yes, but to
DVT.
DVTs, right? So now here's the thing. You have two things going on. So the decrease in peripheral vascular resistance increases the possibility of DVT formation. The other issue is that pregnancy is a hypercoagulable state. So the body is actually forming more, I'm trying not to be overcomplicated here. It's forming more,
Just clotting factors
it's
in general?
more clotting factors in preparation of labor and delivery, because labor and delivery, there's always the risk of hemorrhage. So the body is actually preparing for that. So the components that can prevent bleeding actually increase during pregnancy. So pregnancy is a hypercoagulable state condition. There's already an increased risk of clot formation. And then you have this decrease in peripheral vascular volume.
Professor, even since there is this increase of blood volume and demand, also the valve inside the vein for they suffer or not. Can be like you have mothers who suffer from varicose vein or no?
So I'm not sure that I understand your question, but hang on a second. I might
yeah.
answer it with what I was going to say next anyway.
Okay.
So pregnancy is a hypercoagulable state, but what kind of counters that is the hemodilution. The hemodilution that we spoke about before, the increase in plasma volume. That has something of a protective factor in that it decreases some of this likelihood of clot formation.
What was it called? What kind of dilution?
Hemodilution.
Hemodilution. Okay.
I have a question.
Yes.
I'm trying to relate this just all with the peripheral vascular resistance that is decreasing, which to me increases like the flow of blood. Like,
No, so the peripheral vascular resistance actually, so if you think about it, the vessels in the lower extremity, it decreases. So it doesn't increase the blood flow, it decreases the blood flow.
It decreases the resistance, which would allow things to pass, right?
No, it decreases the resistance is what keeps the vessels tight.
Right.
So if you decrease the resistance, you have more pooling. You have more pooling. That's why you will have more edema.
That
That's
was
why
my
pregnant
question.
moms have.
If you have more
swollen
pooling,
feet.
there's more risk of clot formation.
Sorry, someone's
That's what
I didn't hear.
So Fred, do you understand that the vascular resistance relaxes? So there is more pooling in the lower extremities.
Mm-hmm. That
Do
again.
you understand how you can have more edema from that?
Yes, yes.
You have more pooling. The blood flow isn't flowing as much. It's slower. So there's more time, more likelihood of a clot forming.
Got it. Got it.
Yeah. Okay. All right. So you understand now how the hemodilution is something of a protective factor to prevent that from happening.
Just to make sure I got it. I get it going down. I get it. That's why you're swelling in your feet, and that's why any swelling above the feet would be a big deal, right?
Always concerning. Yeah.
The return is what's going to be really slower. I mean, crap. I have to give it more thought.
Okay. All right. You'll let me know if you have another question. Okay. All right. Okay. So let's see what we have. So we have our cardiac output increased, our peripheral vascular resistance decreased. We talked about the hypercoagulable state, risk of DVTs, and we're going to talk more about peripheral vascular resistance today. Okay, blood pressure. When you're taking a patient's blood pressure during pregnancy, it's important to note not only which arm, but whether the patient was sitting. I mean, we never do it standing essentially, but whether the patient was sitting or whether they were recumbent. Okay, makes a difference. So the blood pressure is going to be lowest in the left lateral recumbent position. And that is actually the optimal position for placental perfusion. So left lateral recumbent, best position for placental perfusion. And that is where the blood pressure is going to be lowest. So if you take the blood pressure, if you took the blood pressure at the last visit, left lateral recumbent, and you didn't chart that, and now I'm taking the blood pressure and the patient is sitting up and I see an increase, I might be concerned, not realizing that some of that is just simply due to positioning. Okay, so it's important not just to document the arm, but the patient's position. Let me see if there's anything else I wanted to talk about. Okay, so pooling, back to the pooling. I knew there was something else. Okay. So peripheral vascular resistance diminishes. So that can cause pooling and some laxity of the vasculature. So that also predisposes the patient to varicosities.
Yeah, that's one.
Legs, varicosities in the vulva, varicosities to the rectum, which, as you know, are hemorrhoids.
Professor, that was a try to tell you about the valve inside the vein before, because I had that one with my third one.
Yeah.
The
So
vaginal.
the increased risk of varicosities. Okay. So the legs, the vulva, the rectum, which, as we know, are hemorrhoids. Okay. So I think I posted this as a handout as well. So again, you'll see the numbers will vary slightly, but that is not, I don't want you to get caught up in that. I want you to really understand the concept and what is happening, what is going on here, okay? So remember with the H&H, if you're looking at a patient whose baseline is anemia, and now she becomes pregnant, it's going to be very difficult to interpret that CBC because you don't know how much of that is due to her baseline and how much of it is due to the pregnancy. All right. So your assessment has to be expanded. So I'm going to take you back to fundamentals, and you have to think about a patient who is anemic. What are the signs and symptoms that you expect that patient to display? And those are the things that you have to draw in more. You cannot rely on your labs because the normal changes of pregnancy are going to throw you off. All right. So your assessment, and again, I told you last week, first step in the nursing process is crucial, crucial, crucial. It's all about assessment, right? Okay. Respiratory. Oh, effects of position. Yesterday, remember there was this slide and there was something in ultrasound that I said vena cava syndrome. I'm going to put it in the chat box because this is an important point for you to know. Somebody's sending me a question and I can't get, okay. All right. So during pregnancy, you do not want a patient, particularly second and certainly not in the third trimester. You do not want this patient to recline in a supine position. The great vessels, the aorta and the vena cava, will be compressed between the weight of the fetus, and the bony spine. So that compression will minimize perfusion to the brain, will minimize oxygenation to the brain. So you can have a patient that's laying supine and that patient will tell you, I'm lightheaded, I'm dizzy. The patient will become diaphoretic. The same as if a patient is standing upright and becomes faint, right? Because of the lack of oxygen to the brain. So remember that when we're positioning a patient, you do not want them supine. So when you're doing a procedure such as an ultrasound where you would ideally need to have the patient supine, what you need to do is roll up a small towel and place it under one hip so that the patient can be pretty much supine, but the towel will give enough of an angle to release that pressure off of the great vessels.
Under the left hip?
It doesn't matter.
Doesn't matter.
Doesn't really matter because your goal is to take the pressure off the great vessels. Okay. So, supine, I'm gonna write the other, because you may see it referred to, and I will refer to it as both. Vena cava syndrome, supine hypotension. Okay. So you do not want the patient laying in this supine position. All right. One hip. If you put it under both hips, the patient is going to be supine, right? So one hip to relieve the pressure on the vessels. Okay. Respiratory. So respiratory, the respiratory system adapts to provide for the maternal needs and for the fetal needs. So we have maternal tissues that are growing. We have a fetus that is growing. Lots of oxygen needs. So the oxygen requirement increases about 20 to 40%. And that oxygen is going to the uterus. Remember, the tissue is growing. The placenta itself. So don't forget that even though the placenta is serving a function, the placenta itself has to be perfused so that it can do the work it needs to do. So the uterus, the placenta, the fetus, breast tissue, all of that is growing and needs to be oxygenated, all right? So 20 to 40% increase in the oxygen consumption, oxygen requirement. Okay, hormonal factors, progesterone. So our two main hormones that we're going to talk about are progesterone and estrogen. There will be a few others that I'm going to add on today, but progesterone and estrogen are two main ones that we're going to talk about. So progesterone increases. So remember, we need progesterone in adequate amounts to maintain the pregnancy. Secreted initially by the corpus luteum. When the placenta forms, the placenta secretes the progesterone. Okay. Progesterone will increase the sensitivity of the respiratory center in the brainstem. So it's going to increase the sensitivity to CO2. So if your body is more sensitive to CO2, how is it going to respond? If you're more sensitive to CO2, is your body going to hold it more or release it more?
Release it more.
Okay, and how is that going to happen? By definition, what is that?
Hyperventilation, you mean? No.
It is a very mild, because it's not a marked release, a marked increase. So this is going to result in a mild hyperventilation. Yeah. Okay, so progesterone increases the sensitivity, the brain sensitivity to CO2. That is going to result in a mild hyperventilation. Estrogen, on the other hand, not enough to affect this, the acid-base balance. No, remember I said mild, right? The progesterone increases the sensitivity. The body responds to correct it. So the body responds with a mild hyperventilation, but it's not enough to impact your pH balance. No. Okay, so you're not seeing an alkalosis. You won't see any change in the respiratory, in your acid-base balance. It's mild, okay? Estrogen. Estrogen increases the vascularity of the mucous membranes. So I want you to think about this. If it increases the vascularity of the mucous membranes, how does that impact the upper respiratory tract? The upper respiratory
You
tract.
might be coughing more to get rid of the mucus.
So, but how does it impact the?
The oxygenation.
No. So not coughing more. Okay, think about what I said. You said mucus, but I said it increases the vascularity of the mucous membranes. I didn't say mucus production.
Yeah.
So if the vascularity of the mucous membranes is increased, how does that present clinically? Upper respiratory. So when we talk, in terms of anatomy, when I say upper respiratory, what am I talking about? Where am I talking about?
In the lungs.
That's
Upper
lower
respiratory.
respiratory. Upper respiratory is like the nasal pharynx.
Okay,
And
so I'm going to stop you right there. So if we're talking about the nasal pharynx, I want you to think about your nasal pharynx. If the mucous membranes are now, the vascularity is increased, how does that present?
That's going to make everything
runny
slow,
nose.
right? You might get apnea.
Nasal congestion. No.
Nasal congestion. So you guys are going to excretion. You're like, you're way down the road. And I want you got to come back. The vascularity is increased, so she's going to feel like she has a stuffy nose. Okay, so you will very often have patients who are pregnant will tell you, I've had this stuffy nose for months, for weeks. My nose is always stuffy. Okay, you're looking at the hormones, the result of the impact of the hormones. So estrogen increases the vascularity of the mucous membranes. We're going to come back to that today, so keep that in mind. So that increase can result in nasal congestion. Now, when would that say Jasmine, I didn't make it up, right? When might that result? When might that nasal congestion result in a bloody nose, in nosebleeds? When the air is
Dry.
Dry.
So think about that now. I mean, that has happened to me going into like the winter season. I have, my sinuses are shot, so that's a whole other story. But if I go into a room that's really, really, really dry, I will start to feel that. So these moms that have this nasal congestion, going into winter, if they live in an apartment that has a lot of really dry air, it's really very hot. And some apartments are like that. It's very hot during the winter, very dry air. She might need to have a cool mist. She might need to have a cool mist, okay, so that she doesn't have those nosebleeds, all right? So again, part of your teaching, what the nasal congestion is, what's causing it, this is normal, and what you can do to help make yourself more comfortable. Okay. Next hormone in the chat box. What does it sound like that hormone would do? Very complicated question.
Relax.
Maybe relax.
Relaxing.
So this hormone relaxes the ligaments. Relaxes the ligaments. So again, remember the body is maintaining pregnancy, but as time goes on, is preparing for childbirth. So as part of the maintenance of pregnancy, okay, we have a fetus that's growing. The fundal height is ascending. The diaphragm is going up, right? So you would think that that is going to basically squish the lungs, for lack of a better way to put that. But relaxin relaxes the ligaments in the rib cage. And so what happens is the circumference of the rib cage expands to compensate for the diminished capacity this way. All right. So as the diaphragm moves up, you have less capacity. So the rib cage circumference widens. So the lungs expand more this way than up. Okay. So again, the body compensates for the changes. Fred, you're shaking your head. Wow, you don't believe me or you don't like that?
No, I just think the whole process is amazing. That's all.
Okay. I wasn't sure what that meant.
That's all it is. Just like, I'm just like, holy shit, this is just like, wow, like this happens,
Yeah.
that happens, this causes, it's just amazing how the body takes care of itself.
It's this is an amazing machine. It's that much more important that we take care of it, It really is an amazing thing. Okay. So, Palavina, I don't know if I understand your question, or you didn't understand something I said.
I'm sorry, Professor. When you said this way, I was typing. I didn't see what way you pointed. I apologize.
And that's okay. This is the difficulty with this. Okay. So what I said is, as the fundal height is increasing, the diaphragm is moving up, right? So whereas the lungs would expand this way, with the diaphragm moving up, you have less space. So the relaxin relaxes the ligaments of the rib cage, so the circumference expands. So now the lungs can expand this way more because they can't expand as much this way. So the capacity is still the same. Okay. All right. Thank you, Fred, for a nice way of explaining that, and Simona. So the other change is that we have an increase in the tidal volume. Tidal volume increases by 30 to 40%. So despite all of these changes that we've talked about, we really don't have a significant change in the respiratory rate. We really don't have much of a change in the respiratory rate. Tidal volume increases. We have some accommodations physically. We have an increase in oxygen consumption, but we really don't have an increase in the respiratory rate. And so this is just showing some of the structural changes that occurred during the pregnancy. Okay, so before we move on to GI, which you're going to talk more, you're going to type more, and I am going to talk less. Are there any questions about cardiovascular or respiratory changes?
Not at this point.
Okay. All right. So I'm going to cover appetite, and then I'm going to turn it over to you guys. So the appetite typically will increase if she is not nauseated. Now, a lot of that nausea is due to the hormonal shifts. The hormones of pregnancy, HCG, also contributes to some of that nausea and vomiting. And here I'm talking about the normal. I'm not talking about hyperemesis gravidarum. I'm talking about just the normal nausea and vomiting. So the appetite should increase if she's not nauseated. Now, when we talk about the mouth, the esophagus, large intestine, small intestine, I want you to remember the effects of the two hormones that we just spoke about. So we said estrogen increases vascularity and progesterone. What is the other, another effect of progesterone? What is the effect of progesterone on the smooth muscle? What is the effect of progesterone on the smooth muscle?
Relaxation, no?
So yes, Evelina, it relaxes the smooth muscle. So you guys all owe Evelina a Starbucks coffee or something. So yes, it relaxes the smooth muscle. So I want you to keep that in mind. Progesterone relaxes the smooth muscle, estrogen increases vascularity. Now, keeping that in mind, I want you to tell me some of the changes. What change do you anticipate pregnancy making to the mouth, to the gums, to the gingiva?
Can it have increase in gum bleeds?
Correct.
So an increase in bleeding gums due to which hormone?
Estrogen?
Due to estrogen, yes. So now I'm going to ask this question. You can answer it, but I want everyone to think about this. How does that impact your teaching? What are you teaching your patient?
Not to panic.
Soft brush?
Always, first of all, and
Soft brush?
soft toothbrush. Now, are you teaching her to brush more or brush less?
More.
More?
Same.
More.
So you at least the same. Now she has poor hygiene, it might be more, right? But you certainly want her to maintain her dental hygiene. She should be flossing, she should be brushing. She might need a trip to the dentist if she hasn't been in a long time, right? But definitely a soft brush. Remember what I said yesterday about the acidity of bile on the dentition, right? So if this is someone who has a lot of nausea and vomiting, she needs to brush. She needs to brush more because the acidity can impact the dentition, okay? All right. What other effect might we see of estrogen on the mucous membranes of the mouth? And those of you who have, some of you might have experienced this during your own pregnancies. So
Are you
I have one response. So no real change to the taste. Usually there isn't such a change to the taste, but you will have this excessive salivation. So I'm going to put the spelling in the chat box. So dialism, so you should know that term. Excessive salivation, that increase in salivation, right? And that spitting is from the increase in salivation, okay? And again, something to explain to the mom, this is normal, this is caused by the hormones and so on, right? Okay. Now, the esophagus. How might, I'm going to switch hormones. How might progesterone impact the function of the esophagus?
Harder to swallow?
No. So, Jasmine, what says heartburn? What is that heartburn caused by? Well,
Too much
what
acid by the stomach, too much acid.
Increased pressure
is
on
it too
the
much?
cardiac.
So is heartburn caused by too much acid?
There's increased pressure in the cardiac sphincter, having it diluted, so more acid comes up.
Reflux.
So, but the issue is not that there's too much acid, right? What is, why doesn't the sphincter close? So I'm going to take you right back. I want you to think
The muscle relaxation.
what is happening.
The muscle relaxation, smooth muscle, no?
There's a
So-
gastroesophageal reflex.
Right, but what is causing it?
Increase in peristalsis of esophagus.
Progesterone.
What is causing it? I want you to think about the hormones. This is what I'm saying to you.
Progesterone.
Right, so this is where you have to start your thinking, okay? The impact of the progesterone. It relaxes the smooth muscle, and that is what causes the GE reflux. It's not necessarily that she has an increased amount of bile, but it is the progesterone that is relaxing the smooth muscle that is causing the reflux. So what we commonly refer to as heartburn is pyrosis. Okay, pyrosis. So last week I mentioned about how a lot of the words have a Latin origin. So you should be able to look at that and see fire in that word, because that is the root of the word. Okay, so pyrosis, like pyromania, fire. Okay, so progesterone can result in GE reflux and pyrosis. Okay, so thinking about the GI tract, how might progesterone impact the small intestine? Small, we'll get to the large, but we'll start with the small.
Peristalsis, since we are talking about smooth muscles relaxation, no?
But what about peristalsis? Peristalsis, what about it?
It like slow it down. Slow.
Okay. So if you have a slowing of, so I'm going to ask you to put in the chat box. Progesterone causes slower peristalsis in the small intestine. Give me one pro and one con. What are the pros of that? We're talking small. We didn't get to large yet. Small. So I'm seeing constipation, but remember, you're thinking more large, and I'm in the small intestine. I didn't get up to you as yet. You're ahead of me.
Nutrient absorption.
So you might have more absorption of the nutrients because it's moving slower through the tract. So there's more time for the nutrients to be absorbed. But yes, it does delay the emptying time. So that can work kind of against you in that the nutrients are absorbed, but then it slows the motility, entire motility is slowed. So as this is moving on, now you're trying to get this into the large intestine. It is already somewhat dried out, so to speak, and more bulk formation. So it does contribute to, by the time it even gets to the large intestine, you're well on your way to constipation. Okay. So I'll come back to the question about drinking more water in just a second. All right, so we have a couple of things going on. So if you look at your screen, you can see the picture on your left, non-pregnant, the bowel has lots of room to move around, okay? In the middle, we have a 20-week fetus. The bowel is somewhat compressed, but I want you to look at the 30-week, and granted, it's a little bit exaggerated. Look at this 30-week pregnancy and tell me, is this a happy bowel?
This is brutal.
Nope, it's not.
Okay. That is not a happy bowel. It's a very happy fetus, but it's not a happy bowel. Okay. So in addition to the hormones, the physiology of it, I want you to think about the actual anatomy of what's happening here. So anatomically, bowel is being squished. So you've got a bowel being squished and hormones that are diminishing the motility. So there is a definite increased likelihood of constipation. Okay. Now, still looking at this picture, I want you to tell me about this liver. Is that a happy liver? Can you even see the liver? Do you know? Okay,
Yeah,
this is the liver.
yeah.
So you can see how compressed the liver gets as the pregnancy moves on. So the liver actually gets pushed upward and backwards towards the back in the 3rd trimester. The liver function can be altered due to the hemodilution and to the impact of estrogen. So sometimes your liver function studies, if you have a mom that needs liver enzymes drawn, they might be off a little bit.
Sorry, what did you say was the cause? It was position and the hyper, I forgot.
The hemodilution and estrogen. Now you can't see it in this picture, but the gallbladder. So think back to your GI anatomy and physiology, the gallbladder. So what is the impact of progesterone going to be on the gallbladder? Relaxes, I think we've established that it relaxes smooth muscle, right?
More bile flow.
So if the gallbladder is, the motility has slowed down, what is going to happen to the bile within there?
It'll consolidate.
It is going to consolidate and you're going to have bile stone formation. So there is an increased likelihood of gallstone formations in pregnant women. So it is not uncommon to see a diagnosis of cholestasis of pregnancy. So when you look at this is, how am I going to do this? This is when I miss having a whiteboard. And so when we talk about stasis, the word stasis, are we talking about movement or cessation of movement?
Cessation.
Cessation of movement. So when you add that to chole, we're talking about bile that stops, right? So remember what I said last week about breaking down words. So cholestasis of pregnancy, we're talking about just this, that there's an increased likelihood of gallstone formation during pregnancy. And so you will find that many women will need to have a cholecystectomy. Make sure I'm spelling this right. Cholecystectomy. During pregnancy, they might have to have the gallbladder. If it's bad enough, they might have to have the gallbladder removed during pregnancy.
These don't pass naturally at all?
They do, but remember, you have progesterone on board, right? You've got the steady stream. You got to have the steady stream of progesterone to maintain the pregnancy. So if it's not moving, this can be very painful. Yes, fried foods make cholestasis worse. So again, back to your diet teaching for your moms that you know. Now, you might be taking care of somebody who has a history of cholestasis even before the pregnancy. So you know already going into it what your teaching needs to be. You need to tell her about the possibility of this so that she knows how important it is to maintain that diet. So the retention, when the body retains bile salts to excessive amounts, it can result in extreme pruritus. I misspelled that. So these moms will have extremely itchy skin.
Professor, can you just explain a little bit more about pruritus and how it's caused by the hormone?
Because the bile salts deposit in the subcutaneous adipose, the fatty tissue under the skin. It makes the skin more itchy. But I'm not talking about like just mild itchy. I mean like itchy, really frantically itchy skin. Okay. All right. That's the liver. That's the gallbladder. I think we should do urinary and then we'll take a break, okay? If you can hang on another 5 minutes, I'll just tax your brains a few seconds more and then we'll take a break. Okay, so when we look at the urinary system, the bladder, kidneys, ureters, okay, we're the bladder. Oh, you know what? Maybe we should take a break now. I just thought about it. It's going to be a lot. We'll take a break now. I'll come back to this. And I might need to add in a slide. I'm used to having a board. Okay. Let's take a break now. We'll come back at 11:10.
Sounds good.
Okay.
Sure, thank you.
All right.
Okay, thank you.
Come back in. I'll
Brilliant.
see you in a few minutes. Okay.